nutrition now. It's an important topic. Talk about integral and chemical nutrition in detail. I want you to know about the assessment of nutrition in a surgical patient. Now, but that trends are always more important than single value. They need to follow the trends to see what you can. Now, these are direct lines out of daily and latest edition, and each line is a question to you. When we have nutritional assessment, it can either be biochemical assessment or it can be anthropometric assessment. Or it can be anthropometric assessment. So you need to know that there is no single reliable biochemical marker which identifies malnutrition. Serum albumin has been considered as an indicator of poor outcome. But the problem with albumin is that albumin can also be falsely raised in inflammatory conditions, right? So serum-free albumin is a better marker. Is a better marker than serum albumin. A very important here is the definition of significant weight loss. And significant weight loss is unintentional weight loss of more than 10% in 6 months. And that's the sign of ketosis. This is significant weight loss. And this definition is not only asked in MCQ exam, but it is also asked frequently in the Viva. So significant weight loss is unintentional weight loss of more than 10% in 6 months. A BMI of less than 15 is poor outcome. And the anthropometric measurement, skin fold thickness, tells us about body fat, whereas mid-arm circumference tells us about the muscle mass. So these are the points that you need to remember in nutritional assessment of a surgical patient. There is another tool which has been mentioned in both Bailey and in the latest edition, and this is known as the Malnutrition Universal Screening Tool. Now, the Malnutrition Universal Screening Tool takes into account the body mass index, I. It takes into account weight loss score, and it takes into account the acute disease effect score. Acute disease effect score. So these are the three things which it takes into account. And once you calculate this, you will get the overall risk of malnutrition. You get the overall risk of nutritional assessment of a surgical patient. To remember in nutritional assessment. Of a surgical patient. In both Bailey and in the latest edition, and this is known as the Malnutrition Universal Screening Tool. Now, the Malnutrition Universal Screening Tool takes into account the body mass index, the BMI. It takes into account weight loss score, and it takes into account the acute disease effect score. Acute disease effect score. So these are the three things which it takes into account. And once you calculate this, you will get the overall risk of malnutrition. You get the overall risk of malnutrition, where a score of 0 is the low risk, where a score of 0 is low risk, 1 is medium risk, and 2 or more than 2 is high risk. So that is step number 4 of the must score. And once we calculated this, then 5 is the management guideline for each one of these types. If it's a low risk score, all you require is routine clinical care. Nothing significant is required if it is 0. If it is 1, that medium risk, to observe, you have to take a diet, document to do weekly screening and care at home as well. But if the score is 2 or more, that is high risk. You have to treat these patients. You have to refer to a dietitian for nutritional support and to refer to a team-based care. And monthly review is a community and activity required. Now, one thing which you need to remember about the month score is that once you have calculated, then interventions have been given. You have to reassess the score. So reassessment also has to be done. You have to reassess and treat again as well. So this is the malnutrition universal screening tool. So what I want you to remember here is the 5-step process, and I want you to remember which are included in the month score, that is BMI, first score, and a QDB score. We already discussed about nutritional requirements. This I've covered in the module of burns as well. This is the resting energy expenditure. RE is resting energy expenditure, or basal energy expenditure, or basal energy expenditure. BEE is basal energy expenditure. So RE or base BE in normal people like us, it is 1, and this is 20 kilocalories per kg per day. 20 kilocalories per kg per day. Right? Now, if the patient has mild to moderate sepsis, then the nutrition requirement goes up in such a patient, and this becomes 1.4 times. If the patient has severe sepsis, this is going to become 1.8 times. If the patient has severe burns, then it becomes 2 times. That means the calorie requirement in a patient with severe burns is 40 kilocalories per kg per day. Now, how do we fulfill these calories? How do we provide for these calories? So there are 2 methods. You have enteral versus parenteral nutrition. Now, enteral nutrition is when food goes through the gut, that is enteral nutrition. And parenteral nutrition is when it goes to the IV route, that is parenteral nutrition. Now, the first thing which you need to know, enteral versus parenteral, which one is better? So, of course, enteral is better than parenteral. There is no doubt about this. You all know that we eat food through our mouth and we don't inject ourselves every night. So enteral is also better. And what is enteral? This is the most physiological way. This is how nature has made us. So it is more physiological. It is cheap. Now, whatever we eat through the mouth, it is relatively cheap as compared to pushing something through the IV line. So the chaat which you eat, the junk food which you eat, so it is physiological. It is cheap. It maintains the enterohepatic circulation. It prevents cholestasis. And we will discuss later that in parenteral nutrition, when you give parenteral nutrition for a long period of time, there is cholestasis in the jaundice and the bilirubin can go up. So this is prevented by enteral nutrition. Number 4, it maintains the microvilli, the intestinal microvilli. Number 5, it prevents translocation of gut bacteria. It prevents translocation of gut bacteria. What does that mean? We all know that there's bacteria inside our gut and it also requires food. So whatever we eat, some bit of it goes to the bacteria. But if you don't get food through the gut, then this bacteria will go out of the gut in search of food. And when it goes out of the gut in search of food, it can cause infection. So it is for these reasons why enteral nutrition is better than parenteral nutrition. Now, first let's talk about enteral nutrition in detail. So the best route for enteral nutrition is through the oral cavity. You eat food through the mouth. Now, the problem arises if patient cannot eat, then how do we give nutrition to that patient? So, if patient cannot eat, we first have to assess for how long does the patient require nutrition. If the requirement, so we assess the requirement. Now, if the requirement is for less than 2 to 3 weeks, or the requirement can be more than 2 to 3 weeks. So, if the requirement is for less than 2 to 3 weeks, we then have to judge whether there is good gastric emptying or there is poor gastric emptying. So, there is good gastric emptying or there is poor gastric emptying. And how do we get to know about good versus poor gastric emptying? So if there is poor gastric emptying, the patient will have nausea, vomiting, will complain of bloating, repeated bloating. These are signs of poor gastric emptying, right? Which will not be there if the patient has good gastric emptying. So if the patient has good gastric emptying and the requirement is less than 2 to 3 weeks, then the patient will get a rice tube feeding or nasogastric feeding But if it's poor gastric emptying, then this patient is going to get nasojejunal feeding. Right? So let's talk about each one of them because lots and lots of questions have been asked from rice tube. Now, all of you know about rice tube. This is what a rice tube looks like. And a rice tube is also known as an NG tube, a nasogastric tube. And I'm sure as interns or postgraduates, all of you have inserted rice tubes in patients. So the questions which you need to know for the exam, to insert the rice tube, what is the best position of the patient? This question has been asked 2 times in the end exam. It is the sitting position with neck slightly flexed. Sitting position with the neck slightly flexed. This And when we all know the method, we take the right tube, we apply lubricant, put it through one of the nostril which has better opening, and then once it hits the posterior pharyngeal wall, we'll ask the patient to swallow so that the patient can take it inside the stomach. Sometimes the rice tube does get coiled up in the mouth, and if it does get coiled up, you have to pull it out and reinsert it again. How much rice tube to insert? This is another question which has been asked in the exam. And this you can measure from the nose to the ear lobule and ear lobule to the sternum. So this is how we measure the length of the rice tube which is to be inserted. So it is from the nose to ear lobule and from ear lobule to sternum. This will tell us the length of the rice tube which needs to be inserted. Now, how to know if the rice tube is in the right position? So, how to know if in the right position? So, number one, when you put in the rice tube, gastric contents can be aspirated. Gastric contents can be aspirated. So, this is point number one, which will tell us the rice tube is in the right position. And number two, if gastric contents are not aspirated, we can push air through a syringe, we can push air and we can auscultate it. And we can auscultate in epigastrium. So these are the ways how we know that the rice tube is in the right position or not. Sometimes you will notice that the rice tube has 3 lead balls at the end. And basically these lead balls are there so that it can be easily detected when you do an X-ray. So rice tube, I've told you, this is if there's good gastric emptying. If there's poor gastric emptying, we put in a nasojejunal tube. And this is known as a nasojejunal tube. This is a nasojejunal or a Freckas tube which can be inserted in these patients. And we can give nutrition through that. Now, if the requirement is for more than 2 to 3 weeks, so that is what I told you, enteral nutrition, best is if the patient can eat. If the patient cannot eat, the requirement is less than 2 to 3 weeks or more than 2 to 3 weeks. If it is more than 2 to 3 weeks, we will again see if there is good or there's poor gastric emptying or there is poor gastric emptying. So if there's good gastric emptying, then we are going to put in a feeding gastrostomy. Then a feeding gastrostomy will be done. Whereas if there's poor gastric emptying, then we will carry out a feeding jejunostomy. So these are feeding tubes which are put inside the stomach or the jejunum. Now, first thing which we need to know is that which one is better. Is gastrostomy better or jejunostomy is better? So when both have disadvantages and you have to choose the situation. Now you need to know that gastrostomy is more physiological. Right? Stomach, it is more physiological. But the problem with gastrostomy is that there is a higher aspiration risk. There is a higher aspiration risk when it comes to a gastrostomy. So that means that if you stuff in a lot of food inside the stomach, the patient can vomit it out and can aspirate it. So that is a drawback of gastrostomy as compared to jejunostomy. Now, what are the various ways to carry out a gastrostomy? So the various ways to carry out a gastrostomy are the STAM method, the Witzel method, and PEG. Whereas jejunostomy, you just have STAM and Witzel are the only 2 methods for jejunostomy. Right, so I will talk about these methods in detail. And before I do that, I just want you to know that PEG stands for percutaneous endoscopic. Percutaneous endoscopic gastrostomy is what PEG stands for. So the first method for feeding gastrostomy or jejunostomy is known as the STAM method. And STAM method is the stab method. So this is STAM or the stab method. And here what we basically do is we make a stab incision in the bubble. Correct. We make a stab incision using a number 11. Discuss that. And what we basically do is just pierce the bubble and then put in the tube. That is the STAM method. Now the problem with the STAM method is if you look here, when you make the stab incision, this spear can increase. Right? Sometimes the spear can increase. So the problem with the STAM method is that there is more peri-drain leakage. And another thing which you need to know here is that to fix this tube, we use a first string suture. To fix this, the first string suture, which I've already told you in the suturing techniques module. Witzel method, on the other hand, this is the Witzel method. With the Witzel method, what we do is we create a tunnel for the tube. So if this is the wall of the stomach or the jejunum, we will first create a tunnel. That means we keep a tube here, we create a tunnel for the tube, we create a tunnel like this, and then we pierce the wall. Then we pierce the wall. So you can see here, a tunnel has been created, and then I pierce the wall. And that you can see in the image as well. So the advantage of the Witzel method is leakage in the Witzel method. PEG stands for percutaneous endoscopic gastrostomy. So that is a method which can only be used for gastrostomy. And it's going to put in a endoscope, right? So what I do is I take an endoscope, and I'm going to put it inside the mouth. So this is the endoscope. I'm going to put it inside the patient's mouth like this. And then the endoscope comes inside the stomach. I can see the glow coming from inside the stomach, right? You can see the glow coming from inside the stomach. And when you see this glow coming inside the stomach, I'm going to pierce here and I'm going to stomach under vision. I'm going to pierce here and enter the stomach under vision. And I'm going to create a PEG, that is percutaneous endoscopic gastrostomy. Now, to carry out a PEG, 3 methods to do a PEG as well. And the 3 methods of PEG are push, pull, and the introducer method. and the push-pull and the introducer method, right? So these are the ways how we can deliver enteral nutrition in a patient. Now, enteral nutrition, what are the basic principles which you need to know when you are starting the patient on enteral nutrition? So number one, we always start gradually. We always start gradually and then increase the volume and then increase the volume. So it should be started at around 20 to 30 ml per hour and then gradually we should build it up. We should always remember that before next meal, we should always aspirate first. We should always aspirate first, right? So what happens is that supposing you're doing rinse tube feeding or you're doing feeding gastrostomy or jejunostomy feeding, then before you should always aspirate first. And if more than 200 cc of aspirate comes, then we should withhold the next feed. And why is this aspirate coming out? Because it's not moving forward. Because maybe the bowel is in ileus. So if the bowel is in ileus and the food is not moving forward, we will not give the next meal out because it's not moving forward. Because maybe the bowel is in ileus. So if the bowel is in ileus and the food is not moving forward, we will not give the next meal. We are going to hold it. We will hold it. Otherwise, it will not aspirate. Also, in the night time, a break of 4 to 5 hours. A break of 4 to 5 hours during the night time given in these patients. So these are the principles when we are following tube feed. Also, you should remember that after every tube feed, you should flush the tube with saline so that it does not get blocked in these patients for a longer period of time. Now, what are the complications of enteral nutrition? So the complications of enteral nutrition can be divided into tube-related complications. It can be divided into tube-related complications, and it can be divided into feeding regime-related complications. So tube-related complications are the most common overall. This is clearly written in Bailey and the latest revision that tube-related complications are the most common overall complications when it comes to enteral nutrition. What are the tube-related complications? The tube can get blocked, the tube can get displaced, or the tube can get pulled out or kinked. So these are the tube-related complications which you should know about. The feeding complications, the most common feeding problem. The most common feeding problem is osmotic diarrhea. And you need to know why this osmotic diarrhea develops. So I'm sure in the ward you must have seen patients who are undergoing digestive feeding or are getting feeds through the tube. And their attendants how to do feeding so that they can do it at regular intervals. Now these attendants are always sympathetic towards these patients. So if you tell them that you can give milk, you can give dal water, you can give juice through this tube, they will load everything with sugar because they think that if the patient gets more sugar, more energy, faster. This is the bubble, and this is your tube. This is your tube, right? And if you are giving a sugar-rich solution, if I give sugar-rich solution from here, according to the laws of fluid movement, the sugar-rich solution is going to attract more water. It is going to attract more water, and when more water goes into the bubble, it's going to be rapid transit. There will be rapid transit. There will be a flood inside the bubble, and when there is flood, there's going to be osmotic diarrhea. There will be osmotic diarrhea. The other problem is overfeeding, which is why we should gradually increase the feeds and not suddenly start the patient on large quantities of feed. So moving on to parenteral nutrition. What are the indications for parenteral nutrition? These are basically the contraindications for enteral nutrition as well. The indications for parenteral nutrition are prolonged paralytic ileus for more than 72 hours. If the bowel is not functioning for more than 72 hours, you will think of giving PPN to this patient. Second, if it's a short bowel syndrome patient, short bowel syndrome I discussed in detail in the small and large bowel module. Short bowel syndrome, you should know, can be divided into two types, net secretors and net absorbers. So net absorbers and net secretors. So net secretors are those which have less than 100 centimeters of jejunum on them, whereas net absorbers are those which have more than 100 centimeters of jejunum. So those who have more than 100 centimeters of jejunum, they can at least absorb water and sodium, whereas net secretors can't even do that. So these patients with short bowel syndrome are highly dependent on total parenteral nutrition. The other indications are high output fecal fistula. Fecal fistulas also are covered in the small and large bowel module. High output fecal fistulas are those which have more than 500 cc output in 24 hours. And you can see here this image of a fecal fistula. You can see here that there are multiple openings and fecal matter will come out from these sides through the abdomen. And you exactly don't know what is the site. And these patients just keep on losing fluids and micronutrients. Other indications are acute episodes of inflammatory bowel disease, IBD, inflammatory bowel disease. Again, something covered in the small. Large bowel module. And finally, this is very important, the initial phase, and mind you, I'm writing it with a different colored pen so that there's no confusion. The initial phase of acute severe, again, I'm going to underline severe. So initial phase of acute severe pancreatitis. Not every patient requires PPN. Only in the initial phase of acute severe pancreatitis, we give PPN. And if you remember the module on pancreas, I've told you that initiation of enteral nutrition reduces mortality in patients with pancreatitis. So only for a brief period in acute severe, we give PPN, and after that, we again switch to enteral nutrition there. So these are the indications to give total parenteral nutrition. The next question which arises is that what are the routes through which we can give parenteral nutrition? Right? So what are the routes through which parenteral nutrition can be given? So the best route is a central line. The best route is a central line through which we can give total parenteral nutrition. The least preferred for total parenteral nutrition, the least preferred route is peripheral IV line. Peripheral IV line least preferred. Peripheral IV line is least preferred because there's increased rate of thrombophlebitis and thrombosis. Is increased rate of thrombophlebitis because this is sugar-rich solution. So increased rate of thrombophlebitis is there. That is why peripheral IV line, just in case if you have to use one, I told you in the first module that a short length, you will use a short length and a wide bore cannula to give TPN. But the preferred route is a central line. Now, somewhere the middle part where if you can't put in a central line and you can't get the access, then you can put in a inserted central catheter. Is a peripherally inserted central catheter. It is a peripherally inserted central catheter. So we'll talk about each one of them in detail. Central lines are the best way to give total benefit nutrition. And central line, there are certain points which you need to know. The most commonly used vein for central line, the most commonly used vein overall is internal jugular vein, it's IJV. But the most commonly used vein in TPN, for TPN to give nutrition, this is subclavian. And why is there this difference? So you can have central lines. Central lines can either be, you can either have subclavian central lines, you can have IJV central line, internal jugular vein, and you can have femoral central line. Okay. So there are certain points which you need to know regarding all these central lines. The first point is ease of insertion. The ease of insertion. So the ease of insertion is more for femoral than IJV than subclavian, right? So IJV central lines you can easily insert as compared to a subclavian central line, and that will some guidance to improve the accuracy. So this is regarding ease of insertion. Now the risk of infection. The risk of infection, number 1 is femoral, number 2 is IJV, number 3 is subclavian. And because femoral infection and thrombosis, that is why we don't prefer. That is why we don't prefer them. Okay, and finally, you have risk of pneumothorax. So risk of pneumothorax is a maximum in subclavian because we know that subclavian is closely associated with the apex of the lung. It is number 2 in IJV, and if you cause pneumothorax using a femoral central line, you need to be really talented. So I don't think so anyone is so talented that they can cause pneumothorax using a femoral line. So here's pneumothorax is out. So given all these parameters, IJV is the most commonly used vein overall, but subclavian is the one which is preferred in TPN because it has the least risk of infection. Femoral has maximum risk of infection. So this is what a central line looks like, and we put central lines under ultrasound guidance. And I want to show you a small clip of where I'm inserting the chemoport. Now, chemoport essentially is a central line, only the steps are the same, so which I will demonstrate in the video. So this is a video of a chemoport insertion, and you can see I inserted in the IJV. The IJV is the the pulsating carotid here. And this is my needle under ultrasound guidance. I'm going to cannulate it. When I cannulate the internal jugular vein, I'm going to shift the camera focus and you'll see that there's blood coming into my syringe. That means I'm in the internal jugular vein. You can see here. Left-handed surgeon using my left hand. So once I've done that, I'll insert the guide wire. It's the guide wire which is being inserted. And you can see that I confirm the guide wire position using the C arm. So the guide wire is going in the right area. For the chemoport, I create a tunnel. I create a pocket. So if you just insert a central line, you don't need to create a pocket. But so once I've done that, I'll insert the guide wire. It's the guide wire which is being inserted. And you can see that I confirm the guide wire position using the C arm. So the guide wire is going in the right area. For the chemoport, I create a tunnel. I create a pocket below the capsule. If you just insert a central line, you don't need to create a pocket. But This was for a chemo port insertion, which is similar to a central line insertion. So I created a pocket, and then the sheath is introduced. So the sheath has been introduced over the guide wire, and now I'm going to the sheath is being now peeled away, and you can see the catheter is in place. You can see the X-ray that it is going in, and it is at the junction of the SBC and the right atrium, like I told you. Then you just fix the chemo port. That is the chemo port device. The chemo port has also been asked as a question in the exam. So this is a chemo port with which you connect the catheter now, and you can see I can just put in a needle in the chemo port. See that blood is coming out. So I have an access to a central vein now, and through this I can give fluids, I can give nutrition, I can give chemotherapeutic agents. So as you saw in the video, the tip has to be at the junction of the superior vena cava and the right atrium, SVC and right atrium. So you can see in this X-ray that this tip, this central line tip, lies at the junction of SVC and right atria. If it is too deep, if it is inside the atria, ectopics will come. If it is inside the atrium, you will see ectopics on the ECG reading. So that is why, while positioning the central line, the tube positioning is very important. And you should know that always after the central line insertion, we should get a chest X-ray. Right? So this was the chest X-ray of one of my patients that I put in a chemo port. We will always do a chest X-ray after central line insertion. I still remember I was a final year postgraduate, and one of our first year postgraduates, we had taught him how to put in a central line. And he put in a central line, and whenever they do a new procedure, we tell them to follow up that patient closely. Now, he was told to get a chest X-ray done, but he passed on the responsibility to the intern and did not follow that up. And eventually, it was found out that the patient had developed a pneumothorax and required a chest tube insertion. So please remember that pneumothorax can develop after central line insertion, and always get a chest X-ray done once you've inserted a central line. So this was regarding central lines. IV lines or IV cannulas I've already discussed with you in module 1. Line is something which I want to talk about. PICC line is a peripherally inserted central catheter, like I told you. And in a PICC line, what we do is we insert it like a cannula. We insert it like a cannula, but the tip lies like a central line. So it is inserted like a cannula, but the tip lies like a central line. This is a PICC line. You can see this is a PICC line. And PICC lines can be used for nutrition. They can be used for chemotherapy. They can be used for prolonged antibiotic therapy. And PICC lines can be kept in place. PICC lines can be kept in place for 3 to 4 weeks easily. If you maintain a PICC line, you can keep it for 3 to 4 weeks, sometimes longer as well. So these are the various routes through which total parenteral nutrition can be given. Now, what exactly is given in total parenteral nutrition? That is the next thing to talk about. So total parenteral nutrition, TPN or total parenteral nutrition, we need to give 2000 kilocalories to the patient. 2000 kilocalories are to be given, and this comes in 1 liter or 2 liter solutions. This comes in 1 liter or 2 liter solutions. And you must have seen these big white plastic bags containing milkish fluid going into the IV gland. That is the TPN solution. Okay, that is the TPN solution. And TPN solutions can have a combination of fat, protein, and carbohydrates. Right? So it can either be a 3:1, all mixed into one, or it can be 2:1, or it can be 2:1, that is fat and carbohydrate one, 2:1 TPN as well. There are certain TPNs where they add micronutrients to the TPN also. Now, the composition of the TPN, the composition is a 20-30-50 ratio. It's a 20-30. 50-50 ratio, where 50% is carbohydrate, 20% is protein, and 30% is fat. So that is the ratio of fat, carbohydrate, and protein in a solution. In America, there are certain solutions where almost 60 to 70% can be carbohydrate. 60 to 70% is carbohydrate, 10 to 20% is protein, 10 to 20% is fat, and 10 to 20% is fat. So these solutions can have various compositions when we are giving total parental nutrition. Now, depending on the carbohydrate concentration, depending on the carbohydrate content, you can have either a high osmolar or a low osmolar TPN solution. So low osmolar is one which has low carbohydrate content, and high osmolar is one which has high carbohydrate content. So you can have low osmolar or high osmolar TPN solution. Now, the difference between low osmolar and high osmolar is that carbohydrate metabolism you have discussed in biochemistry. Dr. Rebecca has taught you that carbohydrate metabolism is going to produce carbon dioxide and water as the end products. Okay, so if there is increased carbs, then increased CO2 production will be there. Increased CO2 production will be there. And if there's increased CO2 production, the respiratory effort required by the body will be more. So the respiratory quotient is going to be more than 1. Right? These solutions which are more carbohydrate have increased risk of thrombosis as well. They can thrombose the vein as well. Therefore, in a patient with respiratory failure, this question was asked in the exam. In a patient with respiratory failure, supposing you have a patient with COPD who's in the ICU, right? There you will use a low osmolar solution because I want less carbohydrate in this patient so that less CO2 is produced. So we use low osmolar solutions in pulmonary failure. Concept, if you have a patient with renal failure, in renal failure, we don't want to overload the kidneys. So we are going to use in renal failure a low quantity TPN, which has high carbohydrate. So low quantity, high carbohydrate content solution will be used in patients with renal failure. This question was asked in the AIIMS exam. So these are some peculiar points which you need to know regarding TPN. Now, whenever we start the patient on TPN, so we start them gradually and then we gradually increase the quantity of TPN, because if you give too much of TPN all of a sudden, that can lead to complications, which I talk about in a minute. Also, monitoring of these patients on TPN is very important. So what all do we monitor for? We monitor these patients for fever and infections because they have central lines which can get infected. So fever and infections are something which they are monitored for. Daily weight measurement is done. If there is more than 1 kg weight gain per day, then this is a sign of fluid overload. In fact, the earliest sign of fluid overload is weight gain. So if there's more than 1 kg weight gain per day, then that's a sign of fluid overload. Now, another thing which you need to remember is that weight gain, when you start the patient on TPN, the relative would think that the patient will start gaining weight from the next day, right? TPN is expensive, so they think that it should act immediately. But that is not the case. Weight gain usually after TPN starts from the 5th to 7th day. It starts from day 5 to day 7 is when the weight gain is going to start. It does not start from day 1. So that is another thing which you need to remember. And finally, monitoring of a patient who's on TPN. So monitoring of a patient who's on TPN, we monitor daily weight, we monitor vitals. LFT and KFT are once a week, and serum electrolytes are twice a week. Right? So this is the monitoring which is done in a patient who's receiving total parenteral nutrition. Now moving on to the complications of total parenteral nutrition. These complications are extremely important for the exam, and complications of TPN can be divided into central line related complications and feeding regime related complications. extremely important for the applications of total parental nutrition. These complications are extremely important for the exam. And complications of TPN can be divided into central line related complications and feeding regime related complications. Now, the central line related complications of TPN are pneumothorax, which we've already discussed. That is why we need to get an X-ray done after central line insertion. There can be arrhythmias. Again, something which I told you, the tip of the central line where it is placed is very important. Thrombosis. There can be air embolism. The central line can migrate. But the most common central line problem in TPN, the most common central line problem in TPN is catheter-related sepsis. That means the central line acts as a source of infection. The central line acts as a source of infection or sepsis. Sepsis. If the patient is running fever and has a central line in situ, we need to suspect catheter-related sepsis. And if you're suspecting catheter-related sepsis, we can either introduce an endoluminal brush. To take culture sample and then start antibiotics accordingly. Or what we can do is we can remove the line if the fever is not getting corrected with antibiotics, remove the line and send the tip for culture. Send the catheter tip for culture. Right. So that is how we can get to know what is the source of infection in these patients. Concurrently, we will also send a blood culture in these patients who are running fever with a central line in place. So this is the most common central line problem, and I told you subclavian central line have the least risk of infection. The feeding regime complication, the most common overall complication of TPN, and there should be no confusion, most common overall complication of TPN is hypoglycemia. I've already told you that excess weight gain is a sign of fluid overload. This we've already discussed. This is a sign of fluid overload in these patients. Then these patients can also develop cholestasis. Remember, I told you that enteral nutrition maintains the enterohepatic circulation. And if enteral nutrition is not being given, then cholestasis can occur and bilirubin can increase. Right? So cholestasis can occur, bilirubin can increase. And if serum bilirubin is increasing, then we have to stop TPN till it settles down. Right? So we have to monitor this. I told you weekly liver function and kidney function tests are done. And if bilirubin is constantly increasing, we have to hold TPN and then settle down. Other problems with TPN is zinc deficiency. So there can be micronutrient deficiency. and zinc deficiency. The most common micronutrient deficiency seen with TPN. This is the most common micronutrient deficiency seen with TPN, that is the zinc deficiency. Now, these patients who are on TPN, they can develop hyper or hyponatremia, kalemia, phosphatemia, calcemia. So, any metabolic or electrolyte abnormality can develop. Serum electrolytes need to be regulated. These patients who are receiving TPN. And very, very important for the exam, and this has been asked at least 4 or 5 times in the exam, is syndrome. So refeeding syndrome basically develops when large quantities of PTN, are given in a chronically malnourished patient. That is when refeeding syndrome can develop. Right? So what basically happens is that this malnourished state is a catabolic state. The buildings in the body are being broken up to create energy, right? So buildings are being broken down, economy is in bad shape, and you're breaking everything down to survive, right? To survive. So that is a catabolic state. Now, in such a catabolic state, if you suddenly give large quantities of nutrition, if large quantities of PPN is given, then the body is going to shift to the anabolic state. And in the anabolic state, you need to build structures, right? So now the cell, which is the building block, the cell is going to take in phosphate, it is going to take in calcium, and because you're giving more and more fluid or more and more energy to these patients, more glucose to these patients, because of glucose, insulin will be released. And this insulin will also push potassium inside the system, right? So when this happens, what does the patient develop? The patient develops hypocalcemia, hypophosphatemia, hypokalemia, hypo. Calcium. And because you're giving more and more fluid, or more and more energy to these patients, more glucose to these patients, because of glucose, insulin will be released. And this insulin will also push potassium inside the system, right? So when this happens, what does the patient develop? The patient develops hypocalcemia, hypophosphatemia, hypokalemia, hyponatremia. So these are the metabolic abnormalities. Plus, we are giving excessive fluid. We are giving the PPN solution. Plus fluid overload. This can give rise to arrhythmias. Heart failure. And these are the metabolic abnormalities which are seen in refeeding syndrome, which has been asked many, many, many times in the exam. So I've told you how refeeding syndrome develops. I've told you in slight detail because this is also asked as a short note in your college exam. So the next question arises: how to prevent refeeding syndrome? So I told you that we gradually increase the quantity. Number 2, thiamine supplementation has to be given. In these patients. And number 3, strict monitoring of electrolytes. These are the 3 methods by which we can prevent refeeding syndrome. These 3 methods have been asked multiple times in the exam, including the DND exam 3 or 4 years back. So these are the various complications of PPN which you should know about. Complications of PPN is also a short note for your college exams. Now, before we talk about the Another topic in this module, that is post-operative fluid requirement. I just want to show you an image which actually, this was an image of star trails which I clicked when we had gone on a trek. And the reason I'm showing this is you can see the Milky Way and the stars here, and we're talking about milk kind of PPN is this milky solution. So that's why I wanted to show you this image. This was a 30-minute exposure to get these star trails. Unfortunately, my battery ran out, and I could not get a longer exposure to get the star trails, the complete circle. Otherwise, in the longer exposure, I would have got complete circles. Anyway, moving on, post-operative fluid requirement. So we know that after surgery or any surgical patient requires fluid. And what are the things which we need to keep in mind when we are giving fluids to these patients? So we need to take into account insensible losses. Insensible or obligatory losses are there, and these are approximately 30 to 40 ml per kg. These are approximately 30 to 40 ml per kg are these insensible losses. And in addition to this, we have to replace electrolytes. Sodium should be 50 to 90 millimoles per day, potassium 50 millimoles per day, calcium 5 millimoles, and magnesium 1 millimole per day. Now, there are certain things which you need to keep in mind when we are replacing the fluid. A, it should be gold. Directed therapy. It should be goal directed therapy. You should not just blindly replace fluids. You should only replace fluids which the body is losing out. So how do we do this goal directed therapy? We will calculate the insensible losses. We calculate insensible losses. Insensible losses would be 30 to 40 ml per kg. Then you have to add this with Riles tube output. If you have a Riles tube in place, the Riles tube output, whatever is coming out through the nasogastric tube, you will have to replace it with NS plus KCl. NS plus KCl or DNS plus KCl, right? Normal saline plus potassium has to be replaced there. Now, whatever is coming out through drains, if you put in an abdominal drain, and whatever comes out through drain, you replace it using Ringer lactate with solution. I'll tell you what all these solutions, the composition is, because sometimes they've asked questions regarding the composition as well. And finally, urine output. Urine output has to be replaced with NS or DNS, dextrose normal saline, right? This is normal saline, DNS is dextrose normal saline. So these are the rough indicators which we use to replace fluid in a post-operative patient. And this is very important as an intern and a postgraduate to know this, because this is what you have to do day in and day out in the ward. Also, one more thing which you should remember, that potassium replacement is not done on surgery. Potassium replacement not done on day of surgery. So on the day of surgery, no potassium replacement is to be done. Why? Because potassium is an intracellular ion, and when there is injury, when surgery is being done, trauma is there, potassium is going to come out. So potassium will be on post-operative day 0. So we don't replace potassium on day 0. We'll start replacement from the next day. Now this replacement I told you is done using fluids. So you can have crystalloids and colloids. So the crystalloid solutions are Hartmann's solution. Hartmann's is also known as Ringer lactate. You should know this because a lot of times in the exam, they will not mention Ringer lactate, they will mention Hartmann solution, and you can get confused. So please don't get confused. Ringer lactate and Hartmann's is the same. You can have normal saline, dextrose normal saline. These are the crystalloids. And in Hartmann's, you should know that Hartmann's has 131 milliequivalents of sodium, 5 milliequivalents of potassium, 2 milliequivalents of calcium, 111 of chloride, and lactate as well. So this is the only solution which has lactate also. This is the question which has been asked in the exam. Normal saline is 154 and 154 of sodium and chloride. Dextrose normal is 30 of sodium. And gelfusin, hemapsil, and hestard are colloids. These are colloid agents which are used, and colloid agents are usually used for volume expansion, right? And these days, we will first give crystalloids, and only after that, if we need volume expansion, we will use colloids. And better than colloids is to use blood or blood products, but till the time you're arranging blood and blood products, you can give these colloid solutions as well. So these were the basic things which we need to keep in mind when we have to give fluid to patients in the surgery ward. Also, there are certain special situations. There are certain special situations which I want you to know. Number one, in head injury, I've already told you, head injury, we avoid dextrose because this can worsen the cerebral edema. In head injury, we avoid dextrose, and in these patients, we give IV mannitol to reduce the intracranial tension. In renal failure, restrict potassium. We have to restrict the potassium because the kidney's capacity to handle potassium is not there, so we restrict potassium in these patients. And I've already told you that potassium is not given on post-operative day 0. It started from the next day. So these are the points which you need to remember, and that brings us to the end of this module on nutrition. Before the end, as we've been discussing in all modules, what are the topics for final year students which you should know of? Final year modules, what are the topics for final year students which you should know of? Final year students, you can get a short note on refeeding syndrome, on complications of TPN and enteral nutrition. That is another short note which you can get. So these you should prepare well for your exam. Now, before we end this module, let's do some MCQs. The earliest sign of post-operative volume overload, I told you, is weight gain. If there's more than 1 kg per day of weight gain, you should suspect post-operative volume overload. What is the most common complication of supplementary nutrition, enteral or parenteral? This is a direct line out of Sebastian, and this is overfeeding. Overfeeding is the most common complication of both enteral and parenteral nutrition. Which one of the following is not true regarding the malnutrition universal screening tool? It's used for adults. It takes into account BMI, weight loss, and acute disease effect score. This is also true. It has 5 steps. That is also true. One-time measurement is not true. I told you have to repeatedly measure and reassess these patients. A PICC line is inserted in a patient following prolonged antibiotics. While inserting the PICC line, the residents want to know the ideal position of the tip of the PICC line. So I told you the ideal position is in the superior vena cava, just above the right atrium. Right? So the junction of superior vena cava and the right atrium, just above the right atrium, not inside the right atrium. Which one of the following is not true regarding central lines for nutrition? TPN is best delivered through a central line is true. Subclavian central lines have a higher rate of pneumothorax. This is also true. Subclavian central lines are technically easier to insert. This is false. I told you IJP are easier to insert. Hickman lines through the subclavian route are associated with less risk of displacement and wound infection. This is true. So Hickman lines are like central lines only, and subclavian route, least risk of displacement and wound infection are there. Femoral lines have the highest rate of wound infection. This is also correct. Which dietary component is lacking in patients started on TPN? So there is no fiber, right? You can't have fiber in a TPN solution. Which of the following statements is not true regarding refeeding syndrome? Not true. It is associated with hypokalemia, hypophosphatemia, hypomagnesemia, hypocalcemia. This is true. Thiamine supplementation reduces the incidence of refeeding syndrome. This is true. There can be hypomagnesemia also in following refeeding syndrome. And this also you should make a note here. There can be hypomagnesemia also. Strict monitoring of electrolytes should be done once TPN has been started. This is true. Cerebral edema and strokes are the leading cause of death. This is false. It is arrhythmias and heart failure. Following TPN, one expects weight gain. After how much time? After 5 to 7 days is when we expect weight gain. Highest amount of potassium is present in which secretions? So this is another table directly out of Bailey, which tells us the composition of various gastrointestinal secretions. And you need to know that potassium maximum is present in the saliva. Maximum potassium is in the saliva, whereas maximum bicarbonate is in the pancreas. So the correct answer here is saliva. Another question which you should know is, in the ICU, one patient has been receiving TPN since 5 weeks. Which of the following is a false statement? Sudden glucose intolerance is an early sign of sepsis. This is true. Central line should be changed every 2 weeks. This is false. Central line should only be changed if there is infection. Should only be changed if there is infection, not every 2 weeks. Electrolyte should be checked every 2 to 3 days. This is correct. Electricity and blood urea nitrogen should be done once a week. This is also true. Now, a question which was asked in the INI-CET exam, this was a very basic question related to 12th standard biology. So the caloric value of fat, proteins, and carbohydrates. So they had asked that a patient is receiving TPN, and you were asked to calculate the calories if he receives 100 grams of dextrose, 30 grams of amino acids, and 40 grams of lipids. So we know that dextrose is 4 kilocalories per gram, amino acids is also 4 kilocalories, and fat is 9 kilocalories per gram. So you basically had to multiply and add them up, and the answer was 880 kilocalories. That was the correct answer. So this brings us to the end of this module of questions are asked from this module.